Okay. Hello, everyone. Thank you for joining us tonight for the Jefferson Headache Center, the Cluster Center's webinar tonight. We are going to start in a few minutes and let everyone get adjusted. I'm going to also admit everybody who's still waiting. Thank you for bearing with us. My name is Nicole Carter, and I am the new cluster nurse for the Cluster Center. I'm going to give it just a couple more minutes for everyone to come in, and then I'll just give some housekeeping rules and explain how we're going to uh, present our wonderful webinar tonight. All right, everyone. So again, hi, welcome everybody. My name is Nicole. If we haven't met before, I am the new cluster nurse for the Cluster Center here at Jefferson. I'll apologize in the beginning. I have locked my animals out of the room. You might hear them banging on the door, but they won't be barking. They wanted to say hi as well. Everyone, if you would like to turn on your cameras, you can. This session will be recorded. So you can turn on your cameras now and your names will appear. We will have a wonderful session with our psychologist, Susan McCrae, and we will also have Bob Wall and Joe McKay from Clusterbusters talking tonight. We just ask that everyone, you have wonderful questions. We will have questions toward the end of our presentation, and we ask that you would put them in the Q&A chat box. So the Q&A box, not the chat. If you can type those in, and I will be collecting those to present to all our presenters. We also have Dr. Young, Dr. Nahas, Dr. Amora are also joining us today, and I will compile those and then I will read them off. Not to be distracted, I'll turn off my camera so you can see the wonderful presentation, and we just really want to get going so that we can all get all this information done in an hour and let you guys enjoy the rest of your evening. All right.
Okay, are you ready for me to get started, Nicole?
Yeah. Yes. Sorry. And I can actually give an introduction for Dr. Susan McCrae. You know, she's our paying psychologist here at the Jefferson Headache Center, and she provides evidence-based behavioral health care for individuals living with migraine, chronic headache disorders, and complex pain conditions. She's a core member of Jefferson's Cluster and TAC Center, collaborating with a multidisciplinary team to support patients facing some of the most severe and sorry, um, debilitating headache syndromes. So her clinical work initiatives are neural and behavior medicine, cognitive therapy, and psychopsychology. Psychology, sorry, I messed that up, to help patients build resistance, reduce disability, and reclaim quality of life. When she is not at work, Dr. McCrae is a wife and a mother of 4 children and 2 dogs who keep her very busy. All right, thank you. And here she is.
Okay, can everyone hear me? Nicole, you can give me a thumbs up. Okay. Um, and we'll introduce our other speakers when we get to them. I'm going to go ahead and get started. Just a little bit of a preview of our wonderful co-speakers today, Bob Wald and Joe. Okay. What are we going to be talking about today? I'll start with just some of the evidence base for behavioral interventions in cluster headache, uh, starting with what we know and what we don't know. So, what we know is that there are limited RCTs, and what that stands for is randomized controlled trials. There are some promising case series, but a lot of the information that we know is extrapolated from migraine research and research on pain, general pain science and chronic pain research. What we don't know, there is limited evidence that behavioral treatments reduce attack frequency. There is some evidence for this, but again, it's not that high quality research. It's something that we really need more of. What we do know that behavioral medicine can reliably improve are things like anxiety and depression, and can help with distress tolerance, functional impairment that can come with health issues, sleep stability, autonomic regulation, treatment adherence, and quality of life. I want to talk a lot about what the psychological experiences are of patients with cluster headaches. One of my hopes is that some of these themes might resonate with some of you, with all of you, different parts of it, with the hope that that there might be some shared feeling of not feeling alone or isolated, that if any of the things that we talk about tonight resonate with you, you'll know that other people have felt that way as well, and that these are things that we are looking more into on research to better understand and to better create effective treatments for. So one of the things that we know is that the psychological experiences for patients with cluster headaches, that there's a distinction between the psychological experiences during an acute attack, and that's pretty different from the experiences in between cluster headache attacks. We know that psychological experiences can be impacted by how long a person has lived with the condition and whether or not their cluster headaches are episodic or chronic. We know that in the chronic form of cluster headaches, people report increased feelings of despair and depression, typically due directly to a lack of respite from the pain or lack of improvement or breaks from the pain. And for people with episodic cluster headache, there were less despairing due to having those periods of pain freedom, but it can also, that episodic nature of cluster headache can come with an increased uncertainty. So never really being clear when the next painful bout might show up, or when and how it will disrupt life. So the psychological experiences for cluster headache can be broken up into a couple of these different categories. And let me just orient you kind of to what this graphic is showing. There's a line down the middle, and so on one side are the psychological experiences during a cluster headache attack or in the moment of those attacks. And on the other side are the psychological experience in between attacks, and we'll talk through both of those. And then in the middle, there's some psychological experiences that kind of can go in both directions. This was from a study that did semi-structured interviews with 13 adults that were living with both episodic and chronic headache. And there were 5 themes that emerged. And you can see those 5 themes are the ones that have the darker gray color. So the 5 themes that we'll talk about are darkness, battling, shifting, control, and despair. And so what we already know is that cluster headaches is complex and challenging, and it's really important that we get to know more and more about the psychological experiences. We know that psychological processes can help to maintain distress, and that distress can help lead to exacerbating of the pain experience, which is already painful enough. And that we, again, hope more and more treatments will become available and better researched. So I want to kind of just break this down theme by theme, starting with kind of the darkness theme. One of the first things that was identified is the dark quality of cluster headaches. A lot of patients talked about the use otherworldly, with the pain being otherworldly or evil or almost a spiritual atmosphere, or like there's a monster in there or something that's trying to attack me or get me. Cluster headache pain can oftentimes be described using very vivid language, and it comes with a lot of feelings. So sitting in the room with somebody talking about their experiences, both that person as well as the person they're talking to or the provider can feel that sense of loneliness. And there can be a power from that metaphorical or more vivid language. Right? So referring to those attacks as like the monster is out to get me. Sometimes that can create better understanding of the experience of both people, even the provider, is really understanding what the person is talking about. So that's one of the ideas, is that this vivid way of describing the pain or the experiences can help others relate to what's otherwise could be considered an invisible condition, and at times that can help invoke empathy as well. The other part of that darkness is that there are dark cognitions or dark thoughts that come during those moments when you're in the attack. So, dark cognitions can include really negative feelings about yourself, others, or the world, and they also can often include suicidal ideation. So, many of the participants referred to suicidal thoughts at the time of the attack, with the idea that in between attacks, those thoughts really largely went away. And those thoughts of suicidal ideation are not really of wanting to die, but just wanting that pain to stop. In some ways, this finding might be unsurprising, given that cluster headache is known as the suicide headache. And what we do know from research is that it supports that there are higher rates of suicidality amongst people living with chronic, with cluster headache, compared to individuals who don't have headaches at all. And by and large, for the most part, those suicidal thoughts again are contained to being within the attack, and more often than not related to again wanting that pain to stop. One of the things that came up, and I think this is something we need to talk more about, is with cluster headaches being considered the suicide headache. Does that just mean if a patient reports that, it gets checked off as a diagnostic marker? Okay, yep, that makes sense. This person's living with a condition that's called a suicide headache. They're having those suicidal feelings. They meet the criteria. That makes sense within terms of the condition. Or when patients bring this up, if and when should this be a catalyst for getting a referral to mental health support? There's not a clear answer to that, but I think that is important in terms of having those trusted conversations with your providers, and really talking through where you're at and what help do you need from your medical provider, and what additional help is available and might be helpful to you. I also just put a little screenshot on this slide from the Clusterbusters website, just to highlight that they're at the very top. One of the main tabs that you can click on is a tab about suicide prevention. And I think that's a really important resource to have available. I'm also kind of going to just infuse throughout this talk different talking a little bit about different behavioral medicine therapies, as well as just some strategies. This is one that comes up over and over again, this acronym called HOPE. It's an acronym that stands for Hold On, Pain Ends. And this can also be a mantra at times in those really difficult or dark moments, repeating that mantra over and over to yourself. Or even thinking about if there's a certain place, if there's a room that you go to, if there's a place where your oxygen tank is. Even, this is one version on the internet. There's lots of different colors, and printing out one that resonates with you, having it near your oxygen tank, or having it in that place that you know that you might be, just as a visual reminder of this hope, a visual reminder and cue to hold on, that the pain will end. Okay. Another theme that often comes up is battling. And that kind of can go in two different directions. In the moment of the attack, it's battling with the pain. And in between attacks, it's battling for recognition, for better diagnosis, for better knowledge for yourself, but also finding providers that are knowledgeable and well informed and able to connect you with the treatments that you need and deserve. Um, and so a couple of the themes that came up within this battling with the pain were related to the patients living with cluster headache becoming behaviorally agitated throughout the attack. Um, in um, in some ways, that actual agitation can be used to differentiate cluster headache from other primary headaches. Agitated behavior arguably relates to fear. And there's a fear, anxiety, and avoidance model of chronic pain that fits within kind of this theme. So what is that model? The model of fear, anxiety, and avoidance proposes that when one perceives pain, their appraisal of the pain can influence their behavior and physiological response. So, for example, if pain is catastrophized, right, if you're filled with more of those dark thoughts and negative feelings, or even thinking that the condition is a monster, kind of going back to that darkness theme, this can result in some physiological arousal. It can also trigger some escape or defense behaviors, right? If a monster is coming to get you and coming to attack you, that can really elicit that fight or flight response. So you're wanting to fight the monster or escape from it. Arousal in that way gets your sympathetic nervous system going, increases heart rate and muscle tension, which can exacerbate pain. Out of the people they interviewed, and the patients that I talked to as well, there seems to be a self-learning over time that battling is not as helpful compared to trying to relax. Um, I also wanted to quickly share, there's a lot of words here. We're not going to go through all of them, but this is just a little visual. I really like visual guides too. That fear, anxiety, and avoidance cycle, right? It's the idea that anxiety, that a situation can trigger anxiety and can trigger that anxious response that includes physical symptoms, thoughts, and feelings. That this promotes a really strong feeling to want to avoid those triggers, or to escape them, or to escape anything that's uncomfortable, like canceling plans, not scheduling a vacation. That avoidance can actually lead to temporary relief. So avoiding the trigger can lessen the discomfort temporarily, but in the long term, this is not really helpful. It comes at a pretty big cost. Missing out on life, missing out on living, um, and coming to rely on avoidance. And this can lead to intensification. So you can begin to associate avoidance with feeling better. And as a result, the next time there's a similar situation, the anxiety can get even worse, and it's even more attempting to go into avoidance. Again, I want to talk a little bit just from an overview perspective of different psychological treatments. One of them is DBT. And what does that stand for? That stands for dialectical behavior therapy. And here are the core tenets of dialectical behavior therapy. Mindfulness, which is a method of training to focus on the present moment. Distress tolerance, which are techniques and strategies for distraction, coping, and self-soothing. Emotional regulation, so being able to recognize, label, and adjust emotions. And interpersonal effectiveness, improving the ability to communicate, both during a cluster headache attack. What do you need? Do you need help from your spouse or your support person? Do you need them to give you some space or time alone? What is it that you need, and being able to communicate that? One of the strategies from DBT that I wanted to share with everyone tonight is called the TIP skills. So TIP is an acronym that stands for uh, temperature, intense exercise, and there's two P's, paced breathing and paired muscle relaxation. So one of the ideas here is that you can change your body chemistry. And when pain is really high and intense, emotions can be high and intense, and there's that agitation. That's a really hard moment to tell someone just to relax and to calm down. That can be very, very difficult, if not impossible. And so this strategy starts with the T and the I, doing other things like extreme temperature changes. The example I have here is for cold water, and there's something called the dive reflex. That's the idea that if you plunge your face into a cold bowl of water, that can activate this dive reflex, which can drop your heart rate very rapidly and help to reduce some of that arousal that comes with that intense pain and agitation and anxiety. The I stands for intense exercise, and it's often the case for people living with cluster headaches that in those moments of pain, there's compared to migraine, where someone with migraine might prefer to lay down and be still and in a dark room. With a cluster headache attack, it's very agitating. And sometimes meeting that agitation, meeting that arousal where it's at through intense exercise can be a way to come up and meet it where it's at, and then working through some of that energy and agitation, and then doing some of those more calming strategies like paced breathing or muscle relaxation. Um, uh, as that pain starts to relieve, as the intensity of it starts to relieve, that's a better time to engage in more of those calming or relaxation strategies. In that moment where you're agitated and wanting to pace, meeting your brain and nervous system where they're at, it can be more effective. And this term battling that we're talking about, or this theme of battling, in between attacks is also for recognition. So it involves those feelings of being misunderstood by people around you, or especially by the healthcare system. There were some people who also brought up the idea of disliking the term cluster headaches, feeling that that word headache really undermines the severity of the condition, because really this is not just a headache. In terms of this battling and a hope for better recognition, again, I wanted to come back to some of the things that I think are so incredibly helpful from the Clusterbusters website. This is just a short sampling of their advocacy for cluster headaches page that is really chock full with some good information and good advice. One of the ideas is to become your own advocate, finding the right doctor, recognizing and understanding that it might take some trial and error. When you do find the right doctor, knowing today that can mean months on a waiting list, and waiting a long time to get in with the doctor, could be helpful to be clear about what you're experiencing and what you need, and to be and to ask for it to be reassessed, to make sure you have the correct diagnosis, and advocating if you need to try a new treatment. Engaging with the healthcare system can be overwhelming and an aggravating process, and Clusterbusters does have support groups that are available to help. Keeping yourself educated and informed on your own condition is one of the first steps to becoming an advocate. And after you've become a pro at advocating for yourself, there are also a variety of events and projects that you can become a part of, including, and I just put a few of those here, social media advocacy, Headache on the Hill, which is an annual advocacy event typically held in February in Washington, D.C., with our partners, with a group of the Alliance for Headache Disorders Advocacy, or the AHDA, and they go every year. And they get a group of people together in DC to talk with their state representatives and congresspersons to advocate for adequate funding the adequate funding gets put towards headache research and improving legislation for people living with head pain and disability. There's also events like a virtual walk, support groups through Clusterbusters, but also regional and even international support groups and opportunities to volunteer. So now I want to move towards the top of this. Again, we're kind of going in between here in the moment of the TAC and in between attacks. And we're going to look at this shifting, this theme of shifting. So it's shifting between being in and out of pain. So people with cluster headache depict almost like having two lives, almost like having two identities. The experience of shifting is seen in cluster headaches as well as some other chronic illnesses as well. One of the other shifts that can take place is this idea of who I am now compared to who I used to be. So a shift in identity or discrepancy in the identity between now and this previous time or this previous part of one's life. Illness identity can at times almost become so incorporated in someone's identity that it can take over that overall part of sense of their identity. One of the things that we know is getting the correct diagnosis can lead to more acceptance of the illness, and identifying with it in healthy ways helps to support more adaptive ways of coping. It encourages better self and encourages better self advocacy and self-management. Another part of the shifting is talking again with cluster headache patients who have experienced attacks for many years, and shifting from that position of battling, fighting, or escaping from the pain or that monster, and shifting to again getting the correct diagnosis, accepting, and working on different strategies like staying calm, staying relaxed enough not to fight that monster. I wanted to quickly share another psychological therapy called ACT for short, which stands for Acceptance and Commitment Therapy. There is ACT in general, but there are some protocols specifically for ACT in chronic pain. There are no protocols specific to cluster headache. There are core principles of ACT. This little graphic over here is called the hexaflex. The overall goal being psychological flexibility, and through each of these 6 points. So acceptance, which is embracing thoughts, feelings, and sensations without trying to change them. Cognitive diffusion, which is reducing the impact of negative thoughts instead of by trying to change the thought itself, changing how the person interacts with them. Being present in the moment, so staying mindful and focused on the current moment. Self in context, which is the idea of viewing the self or who you are as a consistent perspective, separate from changing the experience. Identifying values, so things that truly matter to the individual, what's worth living for, and then committed action, so taking steps to align with those personal values despite the presence of pain. So now I want to talk about in between attacks. The two themes here are the ideas of control and despair. So starting with control, there's a theme about having the control of knowledge, knowing what the diagnosis is, knowing what the treatments are, knowing what to do about them, and then planning. And a significant number of the participants felt that it was a really huge moment. So just receiving that diagnosis was a huge moment that really started that process of acceptance, started that process of self-learning and self-advocacy, and that can make a difference. One of the other things is development of routines. So patients living with cluster headaches often get very involved in their routines, their medication routines, their routines for managing the pain. That can be helpful, but it can also lead to some psychological dependency on those routines. Um, One of the ideas here, and again, this is not well researched. I really hope this maybe could be part of a deeper and longer conversation, is the idea of self-efficacy. Uh, there are certain, and some research studies looking at self-efficacy in patients with cluster headaches find that an overwhelming number, 50 to 72%, of people are indicating low self-efficacy, meaning low confidence in their ability to handle the situation. We could possibly see how low self-efficacy can lead to things like planning your life around the cluster headaches, um, planning important events during times of the year when you're not expecting there to be as many cluster headaches or bouts, going to great lengths to avoid triggers. One of the things we know is that, again, that dependency on the routine, that dependency on the planning can really lead to some restriction in people's lives. And so it's not about, what's right and what's wrong, but finding a balance. The other theme here is despair. Um, and so let me compare this to where we started with darkness, where darkness, in that darkness theme, there were categories of negative cognitions or negative thoughts throughout the attack. Here, in between attacks, just is this theme of despair. And so this is really a longer term sadness or an exhaustion that comes from living with a condition that's so painful, and really contemplating the significant impact that it has on one's life. I want to talk a little bit diagnostically about the difference between depression and demoralization. I think that this can be important for cluster headache patients and for their providers as well, and to have some conversations about this. There's some overlapping symptoms between the two, like hopelessness, helplessness, and feelings of failure. One of the main differences, let's take a look here. If depression is reduced motivation and anhedonia, anhedonia means I no longer take pleasure in the things that I once enjoyed. But in depression, the idea is more like I know what to do, I just don't want to do it. It won't be fun anymore. Demoralization is more a perceived incompetence. I can't do it, or I won't be able to do it. Rather than I know what to do, and I just can't get the energy to do it. Depression is a diagnosis that you can receive. Demoralization is not a specific diagnosis, but it is an important clinical conversation to have. I want to end by talking about cognitive behavioral therapy. This is one of the most well-researched therapies within headache disorders. Just to give a little bit of an overview of what this is within chronic pain. So it's the idea that there's a connection between all of these things. There's a connection between pain, between our thoughts, between our emotions, and between our behaviors. And that if we look at all of these things together, we can take control over the things that we have more control over, and we can accept the things that we have less control over, and that overall this can help with coping and managing with painful illnesses like cluster headaches. I wanted to share this chart just to show that cognitive behavioral therapy is more than just working on thoughts, or that there are a lot of areas that this can help. So cognitive behavioral therapy can help with physical, psychological, uh, daily functioning, and an overall coping and quality of life. So cognitive behavioral therapy can help reduce pain perception, increase activity. Some of the techniques that includes our pacing, relaxation, and physical exercise. Emotional coping can help reduce feelings of anxiety and depression. And some of those strategies, cognitive restructuring and stress management. Functional and daily activities, so being able to help people increase their participation, getting out of that fear, anxiety, and avoidance cycle. Improving quality of life, including goal setting and great exposure, some of the strategies. And self-management skills, so better adaptation to living with chronic pain. One of the nice things about CBT is that there are lots of accessible formats as well, in-person, web-based, group, and virtual. And finally, I want to give just two quick just case examples to wrap this all together and what this might look like. Here at Jefferson Headache Center, we do have an integrated neuropsychology team that works right alongside with the excellent doctors here. And so these are some of the things that we do in our therapy sessions. So in this example, the patient has episodic cluster headaches. They're currently in week 3 of a cycle. They're reporting intense panic during the first minutes of the attack, and they have difficulty initiating oxygen therapy because he can't quite think straight. So the clinical focus here from my office as a psychologist would be rapid onset coping skills that support oxygen use and reduce that autonomic escalation, so that nervous system arousal. What we do about that? What's the intervention plan? We work on pre-attack planning, so setting up a mask and a tank in a dedicated spot, posting a visual or auditory guide, and having conversations about that so everyone in the household knows this is the spot, this is where to go, these are the guidelines, this is how to follow them, and practicing. The first minute routine, which is having those visual cues or self-statements just to get to that oxygen mask. Could be a quick mantra. Go to the chair, mask on, slow breath out. Go to the chair, mask on, slow breath out. And then just 10 or 15 seconds of a paced exhale. So you've sat down in the chair, deep exhale, and that can lower that intense feeling of panic. During the oxygen, focusing your attention on an anchor, so counting exhales or repeating a neutral phase. And after the attack, making it part of the routine to do 2 minutes of slow breathing plus getting hydration. Again, the overall goal is faster initiation of oxygen, clear instructions, which reduce cognitive load and the need for decision making, reduce sense of panic, and smoother recovery after attacks. And my last case example is a just tolerance script for high intensity attacks. So this is a patient with episodic cluster headache who becomes overwhelmed by agitation and fear during attacks, leading to frantic pacing and difficulty using treatments effectively. The clinical focus here would be having a simple script that can be rehearsed and that can help enhance tolerance of high intensity pain and affect and reduce, again, that autonomic escalation or lowering the nervous system arousal. So for the simple distress tolerance script, it would be step 1, orient. This is an attack. I know what this is. I've gotten through this before. Step 2 is anchor. Take a slow breath out. And again. And then staying with the exhale. Step 3 is act. Move to the oxygen, mask on, 1 step at a time. Step 4 is endure. This is intense and it will pass. I'm doing what helps. And step 5, recover. When it eases, I'll sit, breathe, and let my body settle. The outcome, feeling more in control, less panicked, and being able to more consistently utilize those acute treatments. Okay, and now I will turn the mic over to Joseph McKay. I'll quickly introduce him. So, Joe McKay is a husband and father of two. He's a retired New York City firefighter who now spends his time advocating for the causes closest to his heart, including those causes through his work with Clusterbusters organization, where he serves on the board of directors. He helps with conference planning, and he also is a big part of the Cluster Buddies program. He also works to increase recognition of and to advocate for more equitable policies towards Americans with disabling headache disorders. And when you're ready, Joe, I'll click through the slides.
Okay. Hey guys, how are you? See some familiar faces out there if I've never met you before. Welcome. I'm going to try to condense 25 years of my life with 9/11 and living with cluster headache in about 10 minutes. Um, on September 11th, on 2001, I was off duty helping to run an FDNY fundraiser when we got the news of what was going on downtown. I called my firehouse and I spoke to Shotzi. And Shotzi was working that tour for me so I can go to the fundraiser. Um, I called the firehouse up. I spoke to him briefly, and then um, are you using the slides, Susan? You have the slides? I can't see the slides right now.
Yep, I've got the picture of you with a group of
Okay.
guys.
Okay, so that's yeah. I don't see it right now, but that's okay. So that's Shotzi, I believe, is the guy on the right. Um, so you can click to the next picture, number two.
Okay. Yep, this is a picture
And
of the Twin
of the
Towers.
building. At that point, we watched that and we knew it was no accident. We commandeered a city bus, we filled it with equipment, and we made our way to the World Trade Center. And then when we got there, it was like hell on earth. You had spoken about like that otherworldly feeling.
Yeah.
That was the first time I experienced it. It was like an apocalyptic movie, but it was really happening. And we got to work searching for survivors and putting out fires. Next slide. About 48 hours into the operation, a list of the missing firefighters came out, and Shotzi was on it. Unfortunately, I found out later that his wife was actually at the doctor's office that morning, confirming that she was pregnant with their third child. So it was pretty tough. Out of the 343 firefighters that were killed that day, I knew 26, and four were from my engine company. Next slide. Those are the four guys there. I also lost one of my best friends who was trapped above the fire in the North Tower. And in the months following, we worked on the pile. We were breathing in that toxic air. We were searching for the missing and hoping to bring closure to some families. And if we weren't there, we were helping the families of those we lost or attending funerals and memorials, sometimes as many as 8 in a day. So needless to say, we were not in a good place. And after 6 months of working at ground zero, I thought I had hit rock bottom and it couldn't get any worse. But it did. And I had my first attack. Next slide. I woke up at 1 in the morning feeling like somebody just stabbed me in the eye with an ice pick. You guys know the feeling. I'd never experienced that level of pain before in my life. I thought I was having an aneurysm and that I was going to die. I ended up in the emergency room. The attack lasted for about 90 minutes, and I was sent home later with no answers. The attacks continued at night, mostly after I fell asleep. And after a few nights, I gave up on going to the emergency room because I really found no relief there. I would just bang my head against the wall to distract myself from the pain. So I scheduled an appointment with the neurologist, and a few weeks later, I got a proper diagnosis of cluster headache. Next slide. Today, knowing what I know now, I feel lucky that I got diagnosed so quickly. Um, we know now it takes, on average, anywhere between 5 and 10 years to get diagnosed. Um, so I can't imagine, people going that long not knowing what they have. A few weeks after my diagnosis, the attack stopped and I went in remission. And around the same time next year, the attacks came back with a vengeance. And once again, they came at night, sometimes 2 or 3 after midnight. My doctor had prescribed prednisone and sumatriptan pills. The steroids helped for a bit, but the sumatriptan pills were not very effective, as oftentimes I would vomit them up. And if I did, I felt helpless. Um, My insurance didn't cover the injections, and they only gave me 30 pills a month. When I was getting multiple attacks a day, I had to ride the other ones out. Next slide. During this time, I was still attending 9/11 funerals, because the DNA, was still identifying victims. And after each funeral, I went drinking with the guys from the firehouse. And sure enough, after that, I was guaranteed an attack. Alcohol is always, always a trigger for me. I was also not able to maintain a regular sleep cycle as I worked 24-hour shifts. So if I decided to take a nap during the day, I would be guaranteed to get another hit. Over the years, as you guys know, doctors tried many medications to help us, but had little to no success, and the side effects were pretty horrible. And oxygen wasn't covered by my insurance either. But lucky me, next slide, I had an unlimited
I'm
supply at
sorry
the
to
firehouse.
interrupt you, Joe. Sorry. Um,
It's okay.
so how about you can continue speaking, but it seems like only a couple of us, the presenters, can see the slides. Most
Oh,
of our attendees cannot. So I don't know if Susan, if you can play around with trying to share it again, because he has some great pictures for everyone to see while he, still is discussing everything.
Okay, you got it. I will do that.
Thank you. Sorry to interrupt.
that's okay. I'll wait a minute and see if we can get this figured out. Oh, there we go. Okay. So that's me smiling because I had an unlimited supply of oxygen supplied by the New York City Fire Department that they didn't know about. But that was for me, a game changer to have access to oxygen at that time. Although I only had the ability to get 15 liters per minute, and all we had were the non-rebreathers at the firehouse, it did help take the edge off the pain. I often had attacks while I was on duty, and if we were at a work and fire, the adrenaline must have kept them at bay. But when the fire was over, I was pretty much guaranteed an attack when I was in cycle, and I would run to that oxygen. Next slide, number 9. There was a time when I overheard a few of the guys that I work with talking about me, and they were doubting that my attacks were real. Um, they not believing, not being believed that the pain was real hurt me. Um, and I never confronted them about it because I knew in the end that if I went to a fire and things went bad, that they had my back. Um, I was also being treated at the time for other 9/11 health issues, including sinus problems. I had a sharp spur in my septum, and it was basically touching the other side of my sinus cavity. And anytime I would get a cluster headache or my sinuses would flare up, I would get a puncture wound, and I would have a sinus infection, and that would lead to a lot of other problems that made the cluster headaches even worse. Um, 2010, things got really bad for me. The methods I was using to abort and cope with the attacks were no longer working, and I was on medical leave from the fire department for months. My FDNY doctor had been telling me for years that I really wasn't fit for duty and that I should retire. So, being desperate to escape from the pain, I did. I had to say, I had to give up the best job in the world, being an FDNY firefighter. I really mean that. The next few years were really tough. I had lost my career. I felt like I had lost my identity. I got hooked on 2 different kind of prescription painkillers, and I became depressed. In 2017, my cycle of attacks was lasted for 7 months. My new insurance allowed me to get sumatriptan shots, but only 6 a month. And as many of us do, we hoard these shots. And I began to overuse them. And during that cycle, I was unable to sleep. But during the peak of that cycle, I was unable to sleep for more than 3 hours straight without getting intact. I was a zombie. I couldn't function. I would walk into a room and I would just stand there and freeze. And my wife would have to, grab me and say, "Hello, wake up." But it was at that time when the thoughts of suicide started to fill my head. And I started thinking about how I was going to do it. I figured that, crashing my car into an overpass would probably be the best. But sorry. Um, I just lost my place here. Hold on. So, like I said, I thought about, looking back now when I was at that time thinking about suicide. I think what kept me from doing it was first and foremost the love that I had for my family, and the fact that I had lost a friend, a firefighter friend, to suicide after 9/11, right before that. And I remember how I almost felt angry at him because he had so much to live for. You know. Next slide. Is that slide? Can you slide? I guess. Okay. All right. Being desperate, as a lot of times we are, I searched on the internet and found myself on the Clusterbusters website. And 2 weeks later, I took a 40-hour Amtrak trip to Chicago. I took the train because, like many of us, we have attacks while flying. And by the way, I do not recommend spending 40 hours on Amtrak train and coach while lugging 8 oxygen tanks with you along the way. But I made it to my first Clusterbusters conference. As I walked into the hotel, I noticed a woman on her knees in severe pain, and I recognized it immediately. She was having an attack. This was the first time I saw another person have an attack, and a lot of emotion welled up at the time, knowing the pain that she was in. I ran over to help her, as did as the others at the conference. And as a firefighter, I've seen so many people that were in desperate need of help, but this was different. In a way, like I felt like that was me on the ground. Um, I really can't explain how it made me feel, but um, the conference began, and I started to listening to others' stories, other people with cluster headache. I felt something at the time, but I couldn't put my finger on it. It was not unlike that otherworldly feeling we were talking about before. Um, the doctors there were experts. Dr. Young, Neha, some of you guys, were there, and uh, I listened. I asked questions, and the information I got from there were like pieces of the puzzle um, that I had been looking for a very long time. I heard personal stories. Um, they were heartbreaking at times, but also it was heartwarming to hear from people who were pain free. Um, Shortly after, at the conference, I became emotional. I started to cry. I knew what it was for, and for the first time, I was in a room full of people that got it. They understood the pain. They all knew. And that was life changing for me. I didn't feel alone anymore. I felt connected to everyone in that room. I met a health professional at that conference. He was a trauma therapist who actually served at the World Trade Center as a trauma therapist. He also had cluster headache. I felt more connected to him in any other way because we both shared the pain of cluster headache and the trauma of 9/11. To this day, I can honestly say that was the best therapy session I ever had. Today, I still see a therapist, and I always say it's time well spent. I learned so much at that first Cluster Busters conference. I went home with new treatment options, both prescription and alternatives. But the most important thing I left with at that conference was hope. Hope. And for that reason, thoughts of taking my life are gone forever. That's it. Thank you. There's my family.
Well, thanks a lot, Joe. I get to follow that now. Um, yeah. Um,
See if I can
Sorry about that.
find us here. Hold on.
yeah.
There we go.
So you can skip that. I
All right.
think most or a lot of the people here know who I am, and it's probably
Okay.
less important, anyways. But yeah, I'm the one who started Clusterbusters um, about 25 years ago. First of all, thank you, Joe, for that. It's always the personal stories that touch home with so many people. I also want to um, say that I'm really happy to see one person in this room um, that this is really what he was really instrumental in bringing all of these issues that have been talked about forward. Um, Dr. Larry Shore, I saw his name here. Um, so first of all, I want to thank Jefferson for all they're doing with this and expanding um, their care for cluster patients um, into this direction. Um, when we when you talk about mental health issues with people with cluster headache, um, a lot of them don't even want to go there or hear that or put any of those labels on what we suffer from. A lot of that is well-earned skepticism because a lot of people here have probably been um, misdiagnosed or mistreated or misunderstood and told that their mental health issues and their mental health um, in general was probably the cause of their cluster headaches. Um, they just needed to get over it. Um, need to get out of their depression because it's causing headaches. So for some people here, decades of being told that their clusters were being um, triggered by mental health issues and maybe not being strong enough and things like that, when all along it's the cluster headaches that are causing our mental health issues. It's not the other way around. Um, and that's really something that Clusterbusters has been really trying to get out there for years. And um, we did a lot of great research with Larry Shore on this. Um, we were always told that we didn't really meet all the criteria for post-traumatic stress disorder for one reason or another. I'm not sure why people were trying to protect um, the classification of post-traumatic stress disorder, but they've finally come up with a new name in post-traumatic stress disorder, and they've added the word complex to it, which allows us a little bit closer to be talked about as having such traumatic stress because we are complex. That bomb went off for us an hour ago, and it's going to go off again in a traumatic event at 4 a.m. After I go to bed. Um, so you get some pre-traumatic stress building up in between. Um, some of these things that we're looking at that Susan shared with us on those lists, um, for those of you that were actually reading along and seeing things on the list, a lot of those things we've we have found ourselves or we have shared in the community with others. Um, you know, CBT pacing is one of the things that mental health specialists say that we may want to try doing. Um, there were a lot of things that were like that. A lot of the things that are on the tip skills, those are things that we do that we found out ourselves that we do as coping skills and things to try to get through it. Now, some of you have probably heard me say this before, but um, when I'm in the middle of an attack, and I know a lot of other people are like this, to me, my thoughts seem really clear and crisp, and it's like, wow, I'm really pretty smart. How did I figure that out? And so a lot of things go through our heads when we're in that attack, and yeah, it certainly is. Our suicidal ideation is certainly heightened during an attack. much higher than in between the attacks. But we're sort of laying that foundation of suicidal ideation during that attack, and that's where we're going to start on that foundation in our next attack. Um, but we were never really considered as having any mental health issues until something else would happen. I remember trying to figure out the right spoon to use to gouge my eye out. Should I use a teaspoon or a tablespoon? Should I come in from the top or from the side to make sure that I got it all out? Um, those are the thoughts that I would have during an attack. I would try to figure out what size drill bit I would put into my drill to relieve the pressure. Um, but nobody would think that I was suffering from mental health distress with my cluster headaches until I carried out either gouging my eye out or drilling a hole in my skull. Then I would probably be locked up on the fifth floor of a hospital and have my oxygen taken away and told that I had a mental health disorder. So I really appreciate Jefferson really working hard to learn from the community on the stressors that we all live with and um, offer that help in their practice and to educate the rest of um, all the providers and all the other um, headache specialists and neurologists and everyone else. Um, we have a lot of education that we need to do at a lot of different levels of healthcare. And this is a really important one. And it's not only important for the person that has the cluster headaches. Believe me, it's a traumatic event for your caregiver that is watching you and can't help. Um, we isolate ourselves so that our kids don't see us crawling around on the floor. Um, so then we get used to isolating ourselves and not wanting to talk about it and not talk to anybody and certainly not want to talk to a therapist because they can't help me. They're not going to stop my pain. Um, but honestly, and it's something that we've always noticed from our conferences when people are meeting face to face, that our caregivers are just as traumatized as those of us with cluster headaches. Um, and I hope there's some caregivers on this call listening to some of this stuff. Yeah, we get it. We understand um, how traumatic this is for our caregivers, and that's why we try to isolate ourselves. But they know what's going on behind the door. Um, so I'll leave it there. I know we're getting past
Yeah,
the time
and
here.
and I
So
just maybe wanted to add a comment to what you just said, Bob. That there are different ways to get support. For some people, meeting with a therapist might be the right way, the right method of support. For other people, being part of a peer-to-peer or a support group might be um, a better fit for them. For some people, encouraging their caregivers to get help and support. There are different ways to get that support you need. One of my hopes with, at least from behavioral medicine, is that it will become more and more integrated into the care that people are receiving. So when they go to that health clinic and see their medical doctors, that their medical doctors will be working alongside behavioral health specialists. And the more then that gets put into these like academic medical centers like Jefferson, the more research that will get done, the more treatment manuals. And I don't know that a treatment manual could ever be as good as some of the guides that you have on the Clusterbusters website, but a treatment manual could go into a medical school education or a training program or serve as a clinical guide to providers or centers.
yeah, we all stopped going to ERs because I know the last time I went to an ER. Um, while I was waiting for the doctor, the nurse came in and told me to lay down and be quiet. And if I made any more noise, they weren't going to send a doctor in.
Wow.
Um, I promise you, I did not lay down and I did not stop making noise. But that was the last time I ever went into an ER to try to get help. So, um, yeah, there are a lot of levels that need to be educated. There's a lot of steps and gatekeepers in our healthcare system. Um, it's difficult training them one at a time, but we
Right.
really appreciate your help in doing that at Jefferson. So thank you very much.
Yeah, I want to be respectful of time. Nicole, do you know if there were any questions that we could try to
There
answer
are a
quickly?
couple questions, and so I want to start with Richard. He asked if you could just describe the CBT manual. He's a veteran, so you had said that was available through the VA.
Okay, sure. Right. So what I talked about in my slide, and I'll just go back to it because I know maybe there was a point where not everybody was seeing them. Um, and so what I had talked about cognitive behavioral therapy in general. And I had also mentioned on my slide that there is a manual. It's cognitive behavioral therapy for headache disorders. So it's not, it's all headache disorders, but it is available. You could Google it. It's from the VA. Um, and it takes this cognitive behavioral therapy model. So that overall idea that all of these things are connected with each other. That pain is connected to our thoughts, are connected to our emotions, are connected to our behaviors, and they all have an impact on each other. Um, and At the VA, they've got these headache centers of excellence, which is a pretty phenomenal thing to have. And so they're able to put extra time and effort into coming up with headache specific, right? So taking cognitive behavioral therapy and really making it very specific to headache. And that, again, you can kind of Google CBT for headache at the VA if you want to take a look at that manual. It will come up, it's publicly available. Their website, the VA's website, is also really nice. They've even have kind of some videos uh, related to that CBT manual for headache. They even have like some session by session guides. Some of those, I would say are definitely there for providers. Um, but depending on your level of interest, you could even watch through those as well. I think that that manual is great. I use it in my I have a training program here where we train psychologists as well, and I use that manual in my training program. So all of the psychologists that we train here are very familiar with it, and it's got some good visuals. I like using not just words but having visuals for things, and I use some of the visuals from that manual even in my treatment here, which is many people, not as many veterans, but really great concepts. I hope that answered the question.
Okay, we did have another question, but Dr. Memorial, did you want to say something?
Yeah, Joe, I was interested what's your feeling about, there's been a lot of, I've seen patients like you who've had burn pit exposures or some clear toxic exposures. We know that, heavy metals may be important as a cause of cluster headache. Does it affect you differently knowing that this is something that more than likely is related to doing your job as opposed to something that may be more of a genetic disorder, like usually migraine tends to run in families where this really doesn't. Did that have any effect on you? I mean, it must have been very difficult to have, your coworkers say, I didn't, hey, I didn't get this thing. What's going on? What are your thoughts about it?
Yeah. So the fact is that none of us are really going to know what the real true effects are of 9/11 until we're all gone. Who knows how, the chemicals and the compounds that were made that day had never even been imagined in a lab anywhere. When you take that amount of material, grind it up and heat it up for 99 days at almost over 2,000 degrees, you're going to create things that were never even dreamed of in a lab, and how that affects the human body. it's going to take time. But yeah, there were a lot of crazy diseases that came out of it. I know there's higher rates of headache disorders from bird pit exposures as well. I think the number's like 40%. It's much higher among ground zero and burn pit exposures in the military. That's a tree that needs to be barked up, as they say. I'm gonna continue to push for more collaboration between the World Trade Center and the burn pits registry and see if we can get some answers, and hopefully we could find another missing piece of the puzzle and will help everybody.
The VA does have a burn pits registry. I don't know
Mhm.
what things they test for. Because you can test for heavy metals, but it
Right.
doesn't really explain what's going on in the brain or explain if it's the cause of
Yeah.
headache,
It
unfortunately.
took us 10 years to get cancer covered by the World Trade Center health program to fight the government, 10 years to get them to recognize it. So it's going to be a long fight with the veterans community because there's a lot more people there, and Washington doesn't like, especially these days, doesn't like money for research. So, but we'll keep pushing on. Thank you for the question, though.
We have a Prashi, I hope I'm pronouncing it right, from South Africa. He's asking, is there an international cluster buster support group, specifically in South Africa?
Bob, you want to jump on
I
that, or?
well, yeah, I can jump on it. And I don't have a lot of information. I just spoke to somebody from South Africa, I think a week or so ago. Um, so that was one person. I don't know of a group in South Africa. I know that our online support groups, our Zoom calls, um, are international. We have people from Scotland and Ireland and New Zealand, from all over can get onto our Zoom calls, our support calls. And we are international. I mean, we've had a couple of conferences over in Europe. I don't know of a specific group in South Africa, though, that might be out there. There's probably
But
some people that would love to have a group started. I don't know.
yeah, if you want to start one, please do.
Yeah,
We'll give
we'd
you
be,
whatever kind of support you need to get that going.
yeah, yeah. So,
Okay, I think we have time just for one last question. So we have Travis from Philly, and he said he's had clusters for 9 years. So he's trying to figure out what's the best way to input behavioral health information into his current cluster treatment program.
I think that's an excellent question. I don't know that this would be the place to get that kind of more individualized. But I would say just even by coming to this webinar and learning more about what behavioral medicine treatments there are, what options there are, you know, tonight you learned about a couple of different kinds of therapy. We talked about CBT or cognitive behavioral therapy. We talked about ACT or acceptance and commitment therapy. And we also talked about DBT, which is dialectical behavioral therapy. Here at Jefferson Headache Center, our psychologists are trained to kind of integrate those therapies. We take primarily a CBT because that's the most evidence-based, but we do integrate a lot of these other treatments and therapies that we know to be really helpful. But even just kind of knowing what the heck do those acronyms stand for can be a helpful way for you to start to explore what the, maybe looking further into what each of those kind of treatments are, trying maybe some of the different strategies we talked about tonight, right? So think going back to that tip sheet and giving some of those strategies a try. That temperature change, intense exercise, and then once that pain and that intensity starts to decrease, engaging with more of those calming or relaxation strategies at that point. There's also a lot of really helpful resources on Clusterbusters website, so they don't just provide information about medication treatments. They provide information about alternative treatments, and also different strategies. So even something as simple as just an oxygen guide, how to, what kind of mask to get, how to wear it. Those are all behaviors, right? Putting a mask on is a behavior. So that's a behavioral strategy. And so knowing how to get that information, knowing how to get access to those guides, and then practicing them ahead of time. So not waiting until you're in the middle at that high intensity attack to read through a written guide or watch a video guide, but actually, doing that when you're feeling okay, even practicing it. You don't really, at a time where you don't need the oxygen mask, but practice putting it on, building some of that muscle memory, following along with that guide, so that you're ready to go when you do need it.
Yeah, feel free to write us at Clusterbusters, and we'll get you as much information and help as we can. Just write us at info@clusterbusters.org, or right. I'm sure you can find Susan's email somewhere. I might even give it to you if you write to me first. So yeah, um, we'll get as much help as we can for you.
Okay, can we proceed to Dr. Young? He has an exciting message he wants to tell everyone.
Yes. So approximately in December, we started to have serious trouble getting oxygen for our cluster patients. Something changed in the environment, and the medical device companies were just not coming through. Um, Nicole and I chose the largest of the oxygen suppliers, Adapt Health, and we cold emailed the CEO of Adapt Health, who responded, delegated. We had a meeting with Adapt Health, and they are promising to make oxygen available, and to create a pathway for oxygen for cluster headache, not just in the Philadelphia region, but but they have multiple sites. Nicole, if you could post the adapthealth.com locations website, it shows sites all across the US. Perfect. Um, and, I have a commitment from the company that they will create a pathway for people to efficiently get oxygen who have cluster headache. So this just happened a week or two ago. We're really excited. It's been an incredible uh, journey to do this, and lots of downs and a few ups along the way. And this may be one of the biggest ups in I hope that we'll get actually make it available to, tens of thousands of cluster patients throughout the country.
Yeah, that is well, the best news I've heard in a long time, Bill. I really appreciate the effort that went into this, and yeah, it's incredibly been getting more difficult for people to get oxygen, and
Mhm.
it's been getting worse ever since the pandemic.
Yeah.
Um, and yeah, it's talk about frustration. I'm really happy that you've done this for our community.
Yeah.
It's
I mean,
huge. So yeah,
we simply picked Adapt Health because it was the largest one in our area, and and because their main office was in the Philadelphia area, and I know the congressman, and I was, just thinking maybe I could get some leverage there, but we didn't need it. We just needed to start the conversation. So we're
well,
starting one with the second biggest in our region called Lincare. But the model of, each each medical device location doesn't know anything. Like the person just doesn't have a clue, and they've probably, and they're probably a new hire, and they just don't get it, and they
Yeah.
don't have. So this model of going to the CEO and saying, please make a pathway. There is a sort of in the Medicare, that's category 3. There is a pathway for coverage
Right.
now. And, I think I'm hoping that not just Adapt Health, but other CEOs, and you'll get some of this top-down redirection and making oxygen available for cluster headache. In the meantime, if there's a Adapt Health, they tell me that there's going to be a pathway to get oxygen through Adapt Health.
Oh. Well, yeah, that's fantastic. Lincare used to actually sponsor the old Ouch conferences,
Wow.
and then that stopped for some reason. I don't know. I wasn't with Ouch, but um, yeah, they used to sponsor their conferences.
That's actually good to know.
Yeah,
Because
that's so oxygen has come a long way in the wrong direction for over the last 20 years. So yeah, it took us 10 years to get Medicare to cover it. So anyways,
Hats off to
thank you
you
very
and the
much.
team there. Thank you.
Yep.
thank you.
Well,
Yeah.
thank you, everybody. You'll get an email for the recording of this when it's ready. And again, have a good night and thank you so
Right.
much.
Yep. Thanks
Thanks.
everybody. Thank you.
Bye-bye.
Bye bye.